So we'll move right along now. And the objectives and the outcomes of CRAN's 2024 Early Age-Onset Cancer Symposium have been captured and summarized in a publication in Current Oncology, which came out earlier this year. Our steering committee chair and co-chair of CRAN's Medical Advisory Board, Dr. Michael Rafel, was the lead author of this publication, and he will present the key learnings and calls to action as highlighted in the paper. Dr. Rafel is a medical oncologist and the clinic lead at the Early Age-Onset Colorectal Cancer Clinic at Sunnybrook's Odette Cancer Center. Dr. Rafel, it was a privilege to co-author this publication with you, and I welcome you to our symposium this morning.
Well, good morning, everybody. What a great day to be talking. I'm very, very excited as I'm going to pull up my screen for you here. I'm really glad to be here with you today. It was very interesting to hear the previous session and the strength and the grit that our patients go through, and that's why we do this, to be here to try and help support everybody to make sure that we make a dent in this awful disease. And diseases, as CRAN has expanded their mission to help support all patients with early age onset cancers. So, for those of you who don't know me, my name is Michael Rafel. I'm a GI medical oncologist at the Odette Cancer Center. I am the proud, I think I'm now chair of the CRAN Scientific Advisory Board, co-chair, all good. Happy to help out any way I can. And I'm also the proud co-chair of this year's Early Age Onset Cancer Symposium. And so over the next 20 or so minutes, what I'd like to do is summarize the key findings from our very successful 2024 symposium. All right, let's get going. So I do not have any financial conflicts of interest to declare. And so the objectives of this talk are quite simple. They are to review the key lessons and the action items that we learned from the 2024 symposium. And as Cassandra had mentioned, if you get bored of me speaking, you can refer to the accompanying manuscript that was published in Current Oncology, which will go into the learnings and the next steps in great detail. And that's pictured right here. Okay, so last year's conference was wildly successful, very well attended. And so here are just some stats. I think we're going to outdo all of these numbers this year. There was 18 sessions, 77 speakers, at least 455 registrants from 21 different countries, and at least 30 cancer types and advocacy groups represented. So a very well attended, very broad input session that we learned a lot from. And the symposium goals for last year were ambitious, and the symposium goals for this year are equally ambitious. And so the hope is to advance discussions on actionable strategies and recommendations to facilitate early detection and timely access to diagnostic testing for individuals at risk for early age onset cancer, to address barriers to early detection and diagnosis, including low awareness among primary care providers and the public. You know, as we just heard in that sort of heartbreaking story about the delays that were experienced by Jessica, and gaps in screening eligibility for younger age groups. We also would like to identify methods to transform healthcare systems to support early age onset cancer detection, diagnosis, and care, and to discuss progress made through collaborative actions generated by the previous symposia. All right. But before we talk about how we're going to achieve the symposium goals, I just want to remind everyone about why we're having these symposiums in the first place. We are having these important discussions because there is a rapid rise in early age onset cancers. And of course, very near and dear to my heart and to CRAN is colorectal cancer. And so to illustrate this, I would like to show you just a few statistics for illustration purposes about the epidemic that is early age onset cancer. And there's really no other way to describe it. It is truly an epidemic that we need to address. Okay. So in Canada, 92% of colorectal cancer cases occur in patients over the age of 50 years of age. And accordingly, most colorectal cancer research and early detection efforts have traditionally focused on older Canadians. And these efforts have proven to be quite successful. Of all cancer types reported, the incidence of colorectal cancer is now declining faster than any other cancer in Canada. We can see in this figure that between 1984 and 2019, the age standardized incidence rate of colorectal cancer decreased by about 4% per year in men and 3% per year in women, respectively. And that is good news. We want to keep that going. However, it's important, extremely important rather, to recognize that this overall decline is being driven by a decrease in the incidence of colorectal cancer among adults over the age of 50. These two figures show that over the last 3 decades, there has been a substantial decrease in the incidence of colorectal cancer among men and women over the age of 50 in Canada. By stark contrast, the incidence of early age onset colorectal cancer has risen dramatically in Canada. This is a recent analysis from a contributor to CCRAN, who we work with quite frequently, Darren Brenner, who used the Canadian cancer registries to identify the mean annual percentage increase in the incidence of early age onset colorectal cancer among men and women under the age of 50. And what you can see is an alarming and exponential rise, 4.45% per year among men and 3.47% among men and 4.45% among women, respectively, aged under 50. And of even greater concern, the more recently you are born, the higher risk is of early age onset colorectal cancer. And this is an epidemiological phenomenon referred to as the birth cohort effect. We can see that men and women born in the 1980s now have double the risk of early age onset colorectal cancer compared to their parents' generation. And even more worrisome is that there is an alarming increase in the incidence of early age onset colorectal cancer among very young Canadians. The data shows us, shockingly, that the incidence of colon cancer, is increasing fastest in patients 20 to 29 years old. 20 to 29. Crazy. It's crazy. The largest annual increase in rectal cancer is increasing fastest in 30 to 39-year-olds. Again, crazy, crazy number, 30 to 39-year-olds. And it's important to remind ourselves that these are not just statistics. These are our patients, these are our friends, and these are our family. And it's easy to get lost when you see, plots like this that just like dots on the screen, to get lost and think that these are just numbers, but these are not. These are our patients, these are our families and our friends. And I want to remind people with that, and this is my dear patient, Suzanne Wood, one of the nicest, kindest people you would ever have met. A mother, wife, sister, daughter, friend, lawyer, and a brilliant patient advocate. She also happened to be an amazing knitter, and my children still wear the sweaters that she lovingly knit, despite all the side effects and all the time she was investing in her care. And of course, she was a very active member of CRAN and a panelist at our symposium just last year. Just last year, she was with us, and she died this past year after a courageous battle with metastatic colorectal cancer. And it's not fair. We must dedicate ourselves to Suzanne's memory and to all the other early age onset patients who have died well before their time. We are in desperate, desperate, desperate need of more prevention, more research, more treatments, and better care for those affected by early age onset cancers. To accept the current status is just completely unacceptable. So let's jump in and talk about some of the lessons learned. We don't have time to talk all about them. I'd like to, use this as sort of a bridge point for the symposium this year. So lesson number 1 from the 2024 Early Age-Onset Cancer Symposium. There is a lack of awareness of early age onset cancer, and this contributes to delays. And we heard that perfectly illustrated in the first session. So to illustrate this, CRAN has been doing a ton of work, including the 2024 National Pan-Tumor Patient Survey, where over 100 patients were surveyed and respond, and they identified some very important key themes that we need to take to heart and we need to work on. First, it was found that the healthcare team was dismissive of symptoms, and this was common. 2/3 of respondents felt that their provider minimized their symptoms. And the perceived reasons, as we just heard in Jessica's case, were young age and vague symptoms. Again, we've just shown you the data that young age should not be in any way used to disqualify a potential diagnosis of cancer. We also found in the respondents that self-dismissal of symptoms was common. More than 40% of respondents waited for greater than 5 years to schedule an appointment. And it's important to remember that education is about not only talking to the providers, but about the patients. As we heard, patients are their best advocates. It's unfortunate that the way that the current system is, that it's not sufficiently resourced. And because of that, we need to advocate for ourselves, and we need to advocate to make sure that we are taken seriously when we bring concerns forward. The respondents identified that the most common identified unmet need was the following: improving the timeliness of detection and emphasizing the importance of increasing awareness of early age onset colorectal cancer in both public and healthcare physician spheres. Lesson number 2 from the 2024 Early Age Onset Cancer Symposium. Early onset patients are routinely excluded from screening programs, but there are signs of progress due to advocacy. So here are the current guidelines for colorectal cancer screening in Ontario, and in my opinion, they are largely insufficient and they do not meet the needs of our patients. So in Ontario, only patients who are aged 50 to 74 are eligible for the population level screening. And as you can see in this flow diagram, the only screening modality that patients are routinely offered when they're at average risk is FIT. And I think that this is completely unacceptable. I personally think that any patient of any age should be offered screening. I think we have to be smart about our asks. And so rather than asking to lower the screening age indefinitely, we're working hard to take it step by step, start with 45, bring it down to 40, and go as low as we can, because patients who are worried should be able to get access to screening. Second, I think that FIT is a good test. It is the adage that we've talked about in many of our past conferences is the best screening test is the one that someone will actually do. And so if that's the test that you're going to do, great. But we do know that colonoscopy is the gold standard for identifying polyps, for early intervention, for therapeutics. And so if a patient wants a colonoscopy, a patient should be able to have a colonoscopy. It should be that simple. And we already have amazing evidence from a Canadian context that lowering the screening age is helpful for patients in terms of reducing colorectal cancer cases, colorectal cancer deaths, and in terms of saving costs. And so this is data from our colleagues in BC dating back now over 2 years, where they did a microsimulation modeling study to estimate the association of lowering the age of colorectal cancer screening on outcomes. So in this figure, we can see that in the dark green bar, there are clear benefits of starting screening at age 45 relative to age 50. And the blue bar shows that there's even greater benefits when we can start screening at age 40 relative to 50. So the results show us that screening at the age of 40 results in 18,000 fewer colorectal cancer cases, 18,000 fewer colorectal cancer cases. The benefits can be dramatic. And what we can see is, as I showed you earlier on, there's a birth cohort effect. The more recently you were born, the greater your risk is of developing early age onset colorectal cancer. So the benefits are even greater among patients in Canada who are more recently born. If we then look at colorectal cancer deaths, once again, you can see that there is a dramatic decline in colorectal cancer deaths if we start screening at age 45 and 40. If we were to start screening at age 40, we could potentially avert 8,000 colorectal cancer deaths. And although the costs associated with screening at a younger age would go up initially, of course, if there's a FIT positive, we need to have investigations with colonoscopy and potentially CT scans. The reality is that the total healthcare costs, if we start screening early, will actually go down because it is extremely expensive to take care of someone with an advanced colorectal cancer. Every drug that we have that comes out now costs at least $10,000 a month. And so if we could catch these cases early, of course, the most important thing is that we're going to prevent patients and their families from suffering. But if we want to look at it just from a dollars and cents point of view, it is cost saving to the system as well. So it does good in all domains. And what we need to remind ourselves, and sometimes it's easy to get down and think that we can't make a change, is that advocacy works. We can see that in our colleagues in the breast cancer sphere, they have been very successful in bringing down the screening age for mammography. So now women as young as the age of 40 can self-access to the Ontario Breast Screening Program. And we at CRAN are going to keep up the fight to do the same for colorectal cancer. So in terms of key themes for action and change, we've done a lot of reflection on the symposium from last year and when we're thinking about the planning sessions for this year. So some action items. Action item number one, frontline clinicians need better awareness of the epidemic of early age onset cancers. And in terms of potential solutions, we need to have educational objectives, including starting early in medical school and continuing medical education. We need ongoing patient advocacy efforts like those led by CRAN through traditional media, social media, and through government lobbying. Action item number two, we need to promote self-advocacy and awareness in young adults. In terms of solutions, we need government-funded, well-publicized campaigns to improve public awareness about the epidemic of early age onset cancers. Ongoing patient advocacy efforts like those from CRAN are being needed to empower patients with the support, education, and knowledge they need. I've talked a lot about colon cancer, but we also see that there are other great awareness efforts, for example, from our colleagues at Bladder Cancer Canada. We see these very graphic figures that really stick in your mind. So we need to keep this up. These need to be plastered all over social media, all over physical media. We need to make sure that patients are aware that if they have symptoms, no matter their age, we need to rule out a cancer diagnosis. It may not be the most likely diagnosis. It may not even be in the top 10 most likely diagnosis, but of course, the most serious one that we need to rule out before we go on to other more potentially likely diagnoses. Action item number three, major problem is that our current screening programs are failing early age onset patients. As I just illustrated, early age onset patients are not eligible for the vast majority of screening programs for different cancers in Canada. In terms of solutions, we need to reevaluate our screening programs to capture a younger population that is increasingly at risk for several different types of cancer. We need to remove all barriers. I feel very strongly about this. We need to remove all barriers, including the need for referrals and build capacity. And so if we look to our colleagues again in the breast cancer sphere, in order to enroll into the breast cancer screening program, you do not need a referral from your doctor. So if you, for whatever reason, don't have access to a primary care physician, you are a bit shy, you feel nervous asking about this, it's difficult to bring up the topic of cancer screening, you shouldn't have to. You should say you can log into a website, schedule an appointment just like you would to see your dentist, right? It should be that easy. You want to have a screening test done, you should be able to get it done. Action item number three, we need appropriate funding and allocation of human resources, including imaging technicians, endoscopy nurses, medical laboratory technicians, pathology assistants, to enable timely detection of early onset cancer. And so we need investment in training, more qualified staff, and we need pan-Canadian licensure. This is an not planned, but at the moment, we just got the CMAG today. I was talking about the healthcare crisis. I don't know if with the blurring of the screen you can see it, but there's an epidemic in cancer. Those of you who read CMAG, there is a shortage in all aspects of cancer treatment. So we need to adequately invest in our patients' care. And CRAN is doing this. This is a recent news release that came out where CRAN has been advocating to address the growing shortage of medical laboratory technicians as part of the initiative to improve access to diagnostic testing and comprehensive genomic profiling. Sometimes we forget that healthcare is much more than just doctors and nurses. There's a whole army of people behind the scenes, the people we don't see, like the pathologists, the medical and laboratory technicians, the imaging technicians. We need to support all of these human resources needs in order to be able to provide timely and holistic cancer care. So in conclusion, as I think I'm coming up soon on my time, early age onset cancers will continue to increase in Canada in the foreseeable future. The 2025 Early Age Onset Cancer Symposium will build upon the success of the 2024 symposium, and together, through one resounding voice, all partners can work together to address the rising trend and to make a real difference for patients affected by early age onset cancers. Our patients like Suzanne Wood deserve this to be done in their memory. We need to prevent cancers at an early age. We need to act, we need to work together. And I thank you all for attending this session because it really is important and it really is the spark that we need in order to infect that change. And with that, I'll say thank you for your attention. I'm excited to hear the rest of the speakers, to listen from you, to learn from you, and to work together. Thank you so much.
Thank you so much, Dr. Rafel. That was an awesome presentation, and it really sets the stage very nicely for the rest of our agenda today. You spoke to a lot of the topics that we're going to be digging into in a little bit more detail. So I will remind our audience that you are welcome to ask a question or put a comment in the comment and question bar, which is just below your video stream. Some of the questions coming in now. So Dr. Rafel, it seems like there is so much good work being done by CCRAN and by others. Do you foresee policy being positively impacted by all of this good work that's being done?
Course, otherwise we wouldn't do this. No, everything is everything in healthcare, everything that requires policy change is unfortunately too slow. And that's the reality. It's a big system. There are a lot of different players. There's a lot of different demands on the system. But as I said before, I think if we are to accept the system as it is now, that would be unacceptable. We may not be able to achieve a perfect system, but we can always make it better. And so if we can even prevent one case of colorectal cancer through our advocacy efforts, then we have been successful. Of course, we want to prevent every case. We want to prevent thousands of cases. But I think that although sometimes it feels disheartening, it feels slow, there is slow progress moving forward, and that progress is on the backs of people who take the time to invest in advocacy. And so I think that by attending this conference, you are already making a difference.
I love that. Thank you. Thank you. And just looking through your lens as a physician, what do you think is contributing to driving this increasing risk for the younger population?
So no one knows for sure. But the leading hypothesis is that it has to do with changes in the gut microbiome. We all have these bacteria that exist within our bodies. These are natural, these are normal. Every single one of us has them. But the leading hypothesis is that we are disturbing that through environmental exposures. And those environmental exposures could be dietary related, those could be medicine related, they can be contamination and pollution related. And so there was a very interesting study that actually just came out earlier this year in Nature that looked at almost 1,000 patients with early age onset colorectal cancer to try and understand the mutational signatures that explained the early age onset rise. And they found that there were actually two very, very specific mutations that were indicative of exposure to a specific type of E. coli that produces a toxin called colibactin. And so, that's just one small example of us understanding and learning more about how the gut microbiome can be associated with the development of early age onset colorectal cancer. And so we don't have all the answers, but we're starting to piece it together. What I can tell you is that while we don't know all the answers, we do have some potential solutions that are common sense solutions that we should all be implementing. The first is that we all need to exercise more, myself included. Every single one of us should be exercising. There's very good evidence that increasing central obesity is associated with higher rates of almost all cancers. So the more that you can exercise, I tell my patients they should be exercising 3 to 5 times per week, 30 to 60 minutes at a time, whatever exercise they would like to do. The other aspect is very clear is that our diet is affecting the rates of colorectal cancer and many other cancers for sure. And so we have a wealth of information of healthy diets. We need to dramatically increase the amount of fiber within our diets. There's very, very good evidence that soluble fiber can actually counteract the effects of E. coli, particularly the colobactin producing strains. So the more soluble fiber in your diet, the better. We know very well that we need to reduce ultra-processed foods. There was just a study that came out this week in JAMA Oncology showing there was a dramatic association between ultra-processed foods in women and the development of cancers in general. We need to have more fruits, vegetables, whole grains. We need to minimize red meats. We need to increase the proportion of plants within our diets. So these are all things that are common sense things that we can all do today. And of course, we need to have earlier screening.
Absolutely, we do. Dr. Rayfel, young patients have unique needs that really are deserving of age-appropriate clinics that are really designated to caring for these patients and their needs. We know that you work at a center that has such a clinic, and CRAN is certainly advocating for these clinics to be introduced across Canada. What would your recommendation be to get this done fast or to expand and scale these clinics, these early age onset colorectal cancer clinics across the country?
Yeah, I was really shocked to hear the story of Jessica. Sorry, I hope it was Jessica. I've said that many times.
Yes.
Okay, it was Jessica. Okay. And I was reflecting on a lot of the things that she had to do and advocate for herself, and to push the agenda forward to make sure that she got the care that she needed. Um, and I think that it really speaks to the broader challenges that patients with early age onset cancer have. As you mentioned, they have very unique needs, and they have very important considerations that we need to take. In fact, like they have young children, and we heard about the importance of childcare. We heard about the financial stressors of them just, being in the prime of their work days. They're still paying down their mortgage. They haven't generated a lot of savings. And so they don't have the time to take off months to pursue, if not longer, their treatments. And so something as simple as you might say, oh, a flight to Toronto from Vancouver, that's not a big deal, but it's a big deal in the context of going through everything that you're going through and not working. And so I think that the system is strained already, and the resources that we have in place for all patients are completely insufficient. And so those are just magnified further in patients with early age onset colorectal cancer and other early age onset cancers who have even greater needs. And so, the clinic that we have at Sunnybrook is basically through the dedication of a small number of individuals with support like people like CRAN and other organizations. And we need that across Canada. And, I'm my mentor when I did my fellowship is a guy named Dr. Chris Booth, another GI oncologist in Kingston, and he has, the recent study he published was the Challenge trial, which looked at the importance of exercise in reducing colorectal cancer recurrence. And he makes this compelling argument that we spend a lot of our focus on new drugs, and we spend thousands and thousands of dollars for a single drug every single month, but we cannot gather the resources to support people in the other things that matter, like giving them childcare so that they can attend their appointments, giving them, physical therapy so that they can work on addressing their, the limitations that they have related to the cancer and its side effects. So I think that we really do need a broad reorganization of the cancer system as a whole to focus on patients as a whole. I think we too often think about interventions that are medical based, but we don't think about all the supportive care that's probably just as important, if not more important, than these drugs.
All right. Thank you so much, Dr. Rayfel. So that brings us to the end of this session. Dr. Rayfel, thank you for that wonderful presentation. We have lots of comments and questions coming in. We will do our best to address them post-symposium for those that we don't have time to address live. So keep them coming. We are going to just take a short break as we transition to the next session, and we'll see you there.